A seizure is a paroxysmal motor, sensory, or autonomic event that occurs due to abnormal, excessive, and synchronous electrical discharges from neurons in the brain and usually lasts less than 5 minutes. If a seizure lasts more than 5 minutes, it's called status epilepticus, and the term convulsion refers specifically to motor seizures. Now, a seizure is different from epilepsy. Epilepsy is a chronic disease of the brain that predisposes an individual to having recurrent unprovoked seizures, that is, seizures without a clear triggering cause. Epilepsy is typically diagnosed when an individual has 2 or more unprovoked seizures, separated by at least 24 hours. Epilepsy is also diagnosed when an individual has 1 seizure and a high likelihood of having another. There are many different forms and causes of epilepsy. Seizures are classified into generalized and focal seizures. Generalized seizures arise from both cerebral hemispheres at the same time, while focal seizures arrive from specific areas in one cerebral hemisphere. Now, generalized seizures are classified into motor and non-motor seizures. Regardless of the subtype, generalized seizures almost always cause a sudden impairment of consciousness. Generalized motor seizures include tonic, clonic, tonic-clonic, atonic, and myoclonic seizures. Tonic seizures involve sudden stiffening of the muscles, while clonic seizures involve rhythmic twitching of the muscles. However, these clinical features are usually combined, so individuals commonly have a tonic-clonic seizure. In a generalized tonic-clonic seizure, a person may have a sudden contraction of their vocal cord muscles, causing them to involuntarily scream or cry during a seizure. Contraction of the ocular muscles can cause uprolling of the eyes. Contraction of the oropharyngeal muscles can impair swallowing, causing respiratory secretions to pool in the oropharynx. Contraction of the jaw muscles may cause the individual to bite on their tongue. Individuals with tonic-clonic seizures may also develop urinary and fecal incontinence. After the tonic-clonic seizure ends, individuals enter the period called the post-ictal phase, during which the individual's consciousness is still impaired for minutes to hours, so they seem sluggish and tired or even hard to wake up. Sometimes, if the seizure event was unwitnessed, the post-ictal phase is the only indication that a seizure ever happened, because the affected individual likely won't remember the event itself. Alright, now atonic seizures translates to no muscle tone. Therefore, they are characterized by sudden loss of postural muscle tone lasting 1 to 2 seconds, causing the individual to collapse to the ground out of the blue. The last of the generalized motor seizures are myoclonic seizures, which involve sudden, rapid, shock-like muscle contractions. This sounds a lot like clonic seizures, but the key difference is that in myoclonic seizures, the contractions are much faster, occurring at a rate of about 0.1 seconds, whereas in clonic seizures, the contractions occur at a rate of about 1 to 2 seconds. Alright, moving on to the other arm of generalized seizures, there are the generalized non-motor seizures. These are called absence seizures and are commonly found in children and adolescents. The interesting thing about absence seizures is... Alright, as a quick recap, just kidding, but what just happened is exactly what individuals with absence seizures experience. Episodes are characterized by a sudden, brief loss of consciousness for seconds to minutes without any change in the individual's posture or muscle tone. So they could be sitting down watching an osmosis video and suddenly lose consciousness without falling down, only to wake up at the end of the video. Unfortunately, episodes can occur dozens or even hundreds of times per day, and are classically described by parents and teachers as staring into space, or daydreaming, or being inattentive. In fact, many children with absence seizures are actually misdiagnosed with attention deficit hyperactivity disorder because teachers often presume that a child is just not paying attention. Focal seizures are classified into those that do not impair consciousness, previously called simple partial seizures, and those that impair consciousness, previously called complex partial seizures. Focal seizures that impair consciousness are followed by a post-ictal phase, whereas focal seizures that retain consciousness do not have a post-ictal phase. Now, focal seizures can be motor, sensory, or autonomic depending on the area of the cerebral cortex involved. For example, a focal seizure involving the primary motor cortex can cause tonic or clonic movements on the contralateral extremity, whereas the focal seizure involving the occipital cortex may cause someone to see flashing lights. Sometimes focal seizures may begin as subtle neurological symptoms called auras. During an aura, individuals may exhibit subtle muscle movements called automatisms, such as chewing, lip smacking, or rapid blinking of the eyes. Other interesting forms of aura include smelling unusual odors like kerosene, a rising sensation in the abdomen, or even feelings of fear or déjà vu. Also, an interesting phenomenon that occurs after focal motor seizures is Todd's paralysis, which describes a temporary paralysis of the affected extremity. Finally, it's important to note that focal seizures can spread to both cerebral hemispheres, causing a generalized seizure. When this happens, it's appropriately called secondary generalization of a focal seizure. Naturally, it might be difficult to know if a seizure was generalized tonic-clonic right from the beginning, or if it was a focal seizure that secondarily generalized. However, a history of an aura, unilateral shaking, turning of the head to one side, or Todd's paralysis, which is a focal weakness in part or all of the body after a seizure, is a clue it may have been a focal seizure that secondary generalized. Take that with a grain of salt, though, because the absence of these historical features does not adequately exclude a focal seizure. Alright, now seizures are just a symptom, much like chest pain or shortness of breath, and therefore the causes of seizures are many. We can categorize them based off the mnemonic vitamins. V stands for vascular, which includes ischemic or hemorrhagic strokes, or intracerebral hemorrhage. I is for infection, which includes meningitis, encephalitis, or brain abscess. T is for trauma, especially penetrating traumatic brain injury, such as that from a gunshot. T is also for toxins. This includes drugs of abuse such as cocaine and amphetamine overdose, or alcohol withdrawal, which typically develops 48 hours after the last drink. Additionally, the anti-tuberculosis medication isoniazid can potentially cause seizures secondary to pyridoxine or vitamin B deficiency. The antidepressant bupropion can also cause seizures, especially if given to individuals with eating disorders like anorexia or bulimia. A is for autoimmune, such as central nervous system vasculitis or lupus. M is for metabolic, and this category includes a bell view of electrolyte imbalances, such as hyponatremia or hypocalcemia, or other metabolic imbalances such as hypoglycemia or hyperglycemia, or hyperthyroidism, hepatic encephalopathy in liver disease, or uremic encephalopathy in kidney disease. Also, Wernicke's encephalopathy caused by thiamine deficiency should be considered, especially in alcoholics. I is for idiopathic, which means epilepsy. N is for neoplasm, and S is for the differential diagnosis like psychogenic seizures or syncope. Also, one separate diagnosis that should be specifically considered in pregnant females is eclampsia, which is when a female with preeclampsia develops seizures. Okay, so when an individual presents with a history of a paroxysmal event, it's important to first make sure that the event was truly a seizure. The differential diagnosis of a seizure includes syncope, a non-epileptic spell caused by a functional neurological disorder, a transient ischemic attack or TIA, a migraine, and vertigo. Syncope is usually preceded by a prodrome of lightheadedness or sweating, followed by a brief loss of consciousness lasting seconds. Similar to seizures, tonic or clonic movements can also be present in syncope. Psychogenic seizures can occur in anyone, but some individuals have a history of trauma or abuse. These spells often include features not seen in seizures, including full-body convulsions with retained awareness and pelvic thrusting. TIAs can last anywhere between 5 to 30 minutes and usually present with the symptoms of a stroke, such as hemiparesis, hemisensory loss, or visual loss. Similar to seizures, individuals with migraines can also develop an aura. However, episodes usually last hours and may be associated with visual disturbance. Vertigo can last anywhere from a few minutes to a couple of days. However, symptoms are usually dependent on the position of the individual. Finally, features like tongue biting, as well as the postictal phase of confusion, can be seen in seizures, and are usually absent in other differential diagnosis. For example, individuals with syncope regain full consciousness and alertness only a few seconds after the event. Now, if there was a seizure, the next step is to determine if the individual has had prior seizures, which establishes a diagnosis of epilepsy, or if this is the first time they've had a seizure. If the individual was previously diagnosed with epilepsy and is on anti-epileptic medication, then assess for the adequacy of that therapy. This includes asking if the individual is taking their anti-epileptic medication, has changed medication doses, started a new medication which might alter the levels of their anti-epileptic medication, experiencing any side effects, and measuring the serum levels of the medication if possible. If the serum levels are low, then either increasing the dose of the anti-epileptic medication, changing the medication, or adding another medication may make sense. However, if the individual is adequately taking the medication and serum levels are normal, then this should prompt evaluation for other causes of seizures. For example, someone with epilepsy might develop meningitis. On the other hand, for a first-time seizure, it's important to start by considering potential causes. A diagnostic workup should include a CBC, electrolytes, liver function tests, serum glucose levels, a toxicology screen, and in any woman of childbearing age, a pregnancy test. An electrocardiogram or ECG can also be obtained if syncope is part of the differential. Brain imaging with CT or MRI is only done if a structural lesion is suspected or if no identifiable cause is found on laboratory evaluation. If a brain infection like meningitis is suspected, a lumbar puncture can be obtained. Generally speaking, individuals with first-time seizures are not treated with anti-epileptic medications. If the workup doesn't reveal an identifiable cause, then it's considered an unprovoked seizure, and at this point, we need to start thinking about epilepsy. The next step is performing an electroencephalography, or EEG, which is done by placing electrodes on the scalp and monitoring the brain's activity. Individuals are often stimulated to produce a mini seizure in the brain using techniques such as hyperventilation, where a person takes deep breaths, exposure to bright light, flashing lights for up to 2 minutes, and a degree of sleep deprivation. The EEG tells us whether the epilepsy is generalized or focal. Additionally, it can help with specific diagnoses. For example, a 3 Hz spike and wave pattern on EEG is characteristic of absence seizures. However, a negative EEG does not exclude the diagnosis of epilepsy. Instead, the diagnosis of epilepsy relies on the presence of 2 or more unprovoked seizures. Once epilepsy is diagnosed, the mainstay of treatment is anti-epileptic medication and largely depends on the type of seizure, the convenience of the dosing schedule, and the side effects. In general, the first-line medications for generalized seizures are levetiracetam, valproic acid, lamotrigine, and topiramate. And the first-line medications for focal seizures are carbamazepine, phenytoin, and lamotrigine. Absence seizures are uniquely treated with ethosuximide. However, if an individual with absence seizures also has generalized tonic-clonic seizures, then valproic acid is the medication of choice. If eclampsia is diagnosed, magnesium sulfate is given, followed by a prompt delivery of the baby. Finally, individuals with epilepsy are advised to avoid dangerous situations, such as heights, swimming, and driving a vehicle. Additionally, family members are taught to place the individual on their side to help them avoid aspirating and move any potential harmful objects out of the person's way while calling emergency services for assistance. Now, sometimes an individual presents to the emergency department seizing. If the seizure is lasting more than 5 minutes, or if more than one seizure occurs in rapid succession without a full recovery in between seizures, a diagnosis of status epilepticus is made. That's because more than 5 minutes of ongoing seizure activity carries a high risk of causing permanent damage to the brain and heart, so at that point it's necessary to actively stop the seizure from continuing. Emergency management comes down to the ABCs, that is, airway, breathing, and circulation. Oxygen should be administered, cardiac monitors are placed, and blood pressure is checked frequently. Next, it's crucial to establish intravenous access to take blood for labs and to give medications. Standard labs include CBCs, electrolytes, glucose levels, liver function tests, toxicology screens, anti-epileptic medication levels if the individual is on one, and a pregnancy test if the individual is a woman of childbearing age. Next, the individual is given thiamine followed by glucose. This is because these interventions can rapidly help individuals with Wernicke's encephalopathy or hypoglycemia. Next, the first-line medication given to stop a seizure is the benzodiazepine lorazepam, given intravenously. If the seizure continues, another dose of lorazepam is given. If seizures continue, the next step is to give phenytoin. If seizures continue, another dose of phenytoin is given. If seizures continue, then if an intensive care unit or ICU is available, then the next step is intubation, anesthesia with midazolam or propofol or pentobarbital, along with continuous EEG monitoring. EEG monitoring is necessary at this point because anesthesia can cause paralysis, but that does not mean that the seizure has stopped. Now, if the ICU is not available, the individual is given phenobarbital to help control the seizure. Okay, so in children, one additional common type of seizure is a febrile seizure, which is a seizure triggered by a fever. Febrile seizures usually occur in children between the ages of 6 months to 6 years and peaks around 18 months. Often a febrile seizure follows a respiratory tract infection, commonly after a roseola infection caused by human herpes virus 6 and 7, or HHV6 and HHV7. Febrile seizures are more common in children with a family history of febrile seizures or epilepsy, or those with a pre-existing neurological disorder. Febrile seizures can be either simple or complex. Simple febrile seizures must fulfill all 4 of the following. They must be generalized tonic-clonic seizures, last less than 15 minutes, occur only once in a 24-hour period, and cannot result in a neurological defect. On the other hand, a complex febrile seizure must have any one of the following. The seizure is focal, lasts more than 15 minutes, occurs more than once in a 24-hour period, or results in a neurological deficit. The reason we classify febrile seizures like this is because it will determine whether we investigate further or not. Simple febrile seizures do not need laboratory or imaging investigations. And the individual can be reassured that the risk of developing epilepsy in the future is very low, so they don't need anti-epileptic therapy. Children with simple febrile seizures are at an increased risk for a repeat simple febrile seizure. But even when there's a reoccurrence, as long as it's a simple febrile seizure, a workup doesn't need to be routinely done. On the other hand, complex febrile seizures require further investigation. First, in an individual with a complex febrile seizure, you must make sure that this is not meningitis, so a lumbar puncture may be needed. Also, brain imaging with an MRI should be considered to look for a potential structural lesion. And finally, risk of developing epilepsy after a complex seizure is up to 5%, so an EEG should be done and anti-epileptic therapy may be started. Alright, now there are some specific epilepsy syndromes that primarily occur in children and are important to recognize. Infants can have infantile spasms, which is characterized by bilateral, symmetrical limb and trunk spasms that usually occur when the infant wakes up from sleep. Unlike a generalized tonic-clonic seizure, an infant maintains a normal level of consciousness during the infantile spasms, and there's usually a long pause of more than several seconds between spasms. In between episodes, an EEG classically shows a chaotic pattern called a hypsarrhythmia. Also, a triad of infantile spasms, hypsarrhythmia, and developmental delay is called West syndrome. Interestingly, Infantile spasms can be the first symptom of tuberous sclerosis. Therefore, all infants should get a skin exam using an ultraviolet lamp called a Wood's lamp, which can detect hypopigmented macules that are characteristic of tuberous sclerosis. Infantile spasms are treated with an adrenocorticotropic hormone, or ACTH. Infants on ACTH should be monitored for the risk of developing hypertrophic cardiomyopathy. Now, if the infantile spasms are associated with tuberous sclerosis, then vigabatrin, a gamma-aminobutyric acid or GABA transaminase inhibitor, is the medication of choice. Other syndromes include Lennox-Gastaut syndrome, which is characterized by the triad of developmental delay, multiple seizure types, and an EEG that shows slow spike waves at a rate of 1.5 to 2.5 Hz. Juvenile myoclonic epilepsy is characterized by myoclonic seizures upon awakening and particularly occurs in adolescence. Finally, Landau-Kleffner syndrome is characterized by disturbances in language development and epilepsy. Alright, as a quickish recap, a seizure is a paroxysmal event that occurs due to an abnormal, excessive, and hyposynchronous electrical discharge from the brain. Epilepsy is a chronic disorder of the brain that predisposes the individual to recurrent seizures, and is typically diagnosed when either two or more unprovoked seizures occur, or when one seizure occurs with a high chance of another one happening. Seizures can be classified into generalized and focal seizures. Generalized seizures include tonic, clonic, tonic-clonic, myoclonic, atonic, and absence seizures. Focal seizures include those that do not alter consciousness and those that do. When evaluating an individual with suspected seizure, it's important to first rule out other differential diagnoses like syncope, transient ischemic attacks, and migraine. If it's a true seizure and the individual has a history of epilepsy, then the adequacy of their anti-epileptic medication should be assessed. If the individual is presenting with a first-time seizure, then further investigation into the secondary causes of the seizure should be initiated. This includes laboratory studies like a complete blood count, electrolyte and glucose levels, and a toxicology screen. Additionally, other investigations such as brain imaging, an EEG, or a lumbar puncture should be considered. If no obvious cause is identified, a diagnosis of epilepsy should be considered. Status epilepticus is a seizure lasting more than 5 minutes, or more than one seizure with no recovery in between. When managing status epilepticus, prioritize the airway, breathing, and circulation. Then establish intravenous access, obtain laboratory investigations, and give thiamine followed by glucose. Next, abort the seizure using medications such as the benzodiazepine lorazepam. Finally, in children, febrile seizures and epilepsy syndromes like infantile spasms should be considered. Holy jibber jabber, that took forever to do.